everyone, and welcome. I'm Kim Boyer, President of AIIA Tasmania, and it's great to have you here. Now, I need to explain a couple of things before I welcome you to country and hand over to Ed, who's managing tonight. Number one thing is Nitin, our special guest speaker, has COVID. So that's why we are Zooming him in via Zoom. Thank you very much to Bruno, who's organised the technology to enable this to happen. And that will then be followed by Dick. Now, Ed, our treasurer, but who's also the honorary consul for Poland, is going to coordinate this event. So my only duty tonight is to say welcome and to acknowledge the traditional owners of the land on which we meet on behalf of both the AIIA and the university. I acknowledge and pay respect to the traditional owners of the land on which we meet and pay respect to their elders past and present. This land was never ceded, always was and will be Indigenous land. So with that, I'll hand over to Ed, who will take over the event from here. Thank you.
Thanks, Kim, and I'd also like to express my acknowledgement of country as well. Now, are you with us there, Nitin?
Yes, very much.
So we're right. All right, we're getting some technical advice here from Bruno. As we're all aware, East Timor's been independent from Indonesia for about 25 years now. And it's a progressive country moving on quite nicely. And what you may not be aware of is the relationships that Timor Leste, I used to say East Timor, but Timor Leste has with Australia and particularly Tasmania. Our erstwhile Professor Nitin has been carrying out eye surgery and eye operations and eye programs in East Timor now for about 24 years. And the program has become so successful that it's being taken to other countries in the South Pacific. So well done, Nitin. Now, he's going to tell us a little bit about his work. Now, bear with us with the electronic, but Bruno's going to look after that side of things. After Nitin finishes, I'll introduce Mr. Dick Warner to you, who has also had time in East Timor. We didn't know that when we set up the program. We only knew about Nitin, and somebody on the council said, did we know that Mr. Warner also spent time in East Timor? No. So our Kim went and contacted Mr. Warner, who agreed to come along tonight, share the podium with Nitin. So I think we can look forward to an evening of lots of information, probably take about an hour and perhaps 10 minutes for questions after that. Before I continue, Kim said I'm here as a council member for the AIIA, but I should also like to acknowledge my fellow consul who are here from Thailand, hi there, and from Austria, and I don't see anybody else at the moment. So, yeah, welcome to you as well. So, Nitin, if you're ready, it's over to you, okay? By the way, when Nitin said he had COVID, you'd think an ophthalmologist would come up with something like, something a little more glamorous, conjunctivitis perhaps, or... But we're grateful, Nitin, that you could be with us tonight, even though it's only on the big screen.
Well, thank you, Ed, and thank you, members of the AIIA, Australian Institute of International Affairs. Sorry I couldn't be with you, but I've just come back from Timor and brought some COVID back with me, so I've actually got a few extra days off and give me time to catch up with things that would normally have taken longer. So thank you for asking me to come and share my experiences. I'm not a diplomat, but sometimes it comes to the point of being an amateur in this field. So I really want to start from the beginning, which is where this whole thing started from. And I'm originally from India, and what happens there is so I mean, like all journeys, we must start from the beginning. And I come from India, and when I finished school, I asked my mom, what do you think I should become? And she said, you either become a doctor or an engineer. There was no third option. So I decided to become a doctor, and my younger brother became an engineer. Now, this was way back, but I started my medical school in South India. It was called Christian Medical College. It's a large, why is... So it's got 2,700 beds, and they do almost 2 million outpatients a year. But the thing that I learned there was they never sent anybody back, and they took from the rich, they treated the poor, and I call that sort of compassionate capitalism, which is something that I have, you know, all my life I've practiced. But coming on to eye health, which is the business I am in, eye health is a very important thing because eye problems are quite common. And worldwide, there are about 1.1 billion people living with visual impairment. And as you can imagine, if you close your eyes for 30 seconds, a bad eye health has profound implications for all aspects of life. And certainly there's very good quality evidence that shows that improved eye health is essential to achieve the United Nations Sustainable Development Goals, including those pertaining to poverty, hunger, health, well-being, education, gender equality, and decent work. Really, if you want to build up a nation, you can't not have eye health on top of the agenda. And we also know that 90% of people living with vision or poor vision live in low and middle income countries, or LMICs. And of course, you can imagine what that means when we're trying to help them. The commonest surgical condition that comes in the list is cataract. And so even in the early 80s, when I trained in India, the focus was on eliminating cataract blindness. And actually that hasn't changed now, because even if you see a health system, one of the indicators is what the cataract surgical waiting list is like. And those days we conducted camps, and you see here some pictures from the late 70s and early 80s in camps, what you would see almost 1,200-1,400 people walking in a line, and you had basically 2 seconds to decide whether they will be operated or they won't be operated. When they did get admitted in the ward, you can see how many people there are in the ward. Then they're taken to the operating theater, male and female separate wards. The operating theater had 12 beds, and surgery would normally take the best part of 2 minutes. So in a day, we would do 200, 220 cases. And, patients would spend 3 days in the ward. The complication rates were high, of course, but people who walked in blind walked out with some amount of vision. And so their quality of life improved. But what hit me was the fact that large volume surgery in developing countries and developed countries were not the same. In developed countries, after removing the lens, which forms the cataract, as you see here, that's an opaque lens. After removing it, we didn't replace it with an artificial lens. And so patients got these very thick glasses, which are very difficult to use, but still it was better than being blind. So when I went for my fellowship to Germany, the first thing that I did was I latched onto a project that was working towards developing a much cheaper, affordable IOL intraocular lens. And we patented this, the second one in the world, which was affordable. You see here, that's Gunther Fromberg, my boss at that time. And then we made sure that it was available for a few dollars in all developing countries for a long time. So the Chitrakoot hospital, the one that I showed you earlier, this is what it looks like now. It's a lot more modern, but the volumes, they do close to 780,000 operations a year, most of which are cataract, but they put a lens in. And that's really made all the difference because the outcomes are so much better. Anyway, that's the background. And coming to what's going on in Australia and New Zealand, we are about 1,028 ophthalmologists or eye surgeons in Australia and New Zealand. We have a Royal College called the Royal Australia and New Zealand College of Ophthalmologists, or RANSCO, which oversees the training as well as standards of eye care in the country. So it's a binational college. And if you look at the common diseases of the eye in Australia and New Zealand, it's really macular degeneration, glaucoma, and diabetic eye disease. But if you look at the region, whether it's Australia, New Zealand, or even Indonesia or Papua New Guinea, the problem of maldistribution of eye surgeons and eye care services remains the same. The other problem that we have in Australia, of course, with our indigenous population, which have got a very high prevalence of blindness and visual impairment, which is 3 times that of non-indigenous Australians. So we've got a system where 500,000 people are visually impaired or blind. We have a system that's inequitable, and really we need to address all these things to try and have a more level playing field. A lot of attempts have been made to close this gap, and we have various iterations of implementation of the road gap to close for the roadmap to close the gap for vision. And every year we get a Commonwealth report. We have many reports, but unfortunately most of them don't show much improvement. In fact, the eye sector is one where things have changed. But what is very clear is this closing the gap business is not as easy as many health ministers make it out to be. And in fact, the latest State of the Nation report shows that diabetes, the tsunami of diabetes, is coming. And in the last decade, the increase in the number of people diagnosed with diabetes has increased by 44%, and it's all in the younger age group. And yet we don't have a prevention plan for diabetes, a disease that by change of lifestyle can be affected. And we spent all our time and money working on the complications of the disease. So I was the president of RANSCO during COVID. And after that, after COVID, I was tending to ease off. I went and I sought an appointment with the then health minister, the Honorable Greg Hunt. And I told him that I had come to tell him that I didn't think that he was ready for life, at least in the eye sector after COVID, because the government was so focused on COVID, they'd forgotten about everything else. And that he could not close gaps by simply putting a date on closing the gaps. And I offered him my hand and I said, as a college, we would like to work with the government to help you close these and other gaps. I reminded him that he was the health minister for the country, and if he closed the big gap, all other gaps would close. So anyway, what he said was, let's make a program to do it. And I said, we'll call it 2030 and beyond, because it's really a much longer program. And that's when he asked us as a college to come up with a program for the future. So this was launched in October 22 and was based on 6 pillars that are outlined here, which includes, as you see at the bottom of it, global eye health. But eye doctors have been working on closing the gap for a long time. I mean, you all remember Fred Hollows and the work that he did. The area that he worked on or in was the area of Western New South Wales. It's still known as the Outback Eye Service, and you can see a large part of New South Wales is looked after by this program. So it's got 125,000 people in an area that's the size of France. And what we're seeing here is using road and air to try and reach the unreached, and it's working quite well. Another good model is the one in Western Australia, where it's a much larger area, and they use a van called the Lions Outback Vision Van. And you can see how far the van travels, almost all of Western Australia. That's the van. It's 19 meters long. It's 19 meters because if it was 20 meters, it would require a special vehicle to ride in front of it. Of course, they use air travel. So they've got good stuff going on there. And all these outcomes have halved the wait times for surgery. And, there's an increased accessibility for Aboriginal patients when on-call is there. But how does this translate to money? Because government understands money. If we were to reduce the waiting list for cataract surgery from 12 to 3 months, we would have a public health system cost saving of a few $1 million. And also we'd prevent almost 50,000 falls. I mean, that's a big deal. What you see here is, this is Margaret O'Neill. She used to work with me a long time back, but she's an optometrist and looks after a lot of patients in the West. They're also checking out the role of artificial intelligence along with Google, and have actually put an Aboriginal eye database onto the international map when it comes to artificial intelligence and machine learning. So they're really ahead. The other area that we are pushing hard on is Alice Springs, which has been in the news for all the wrong reasons. But we've been able to get 2 ophthalmologists, one already and one very soon, to be able to carry out services in Alice Springs Hospital that would cover both Alice Springs and Tennant Creek. So all this doesn't happen just on its own. And, on the side, we've been dealing with Canberra, we've been dealing with Wellington also, because like we've got a Vision 2030 and beyond for Australia, we've got a Vision 2030 and beyond for New Zealand, which is a different health system, but the problems are exactly the same. So a lot of this goes on with advocacy, and I've learned a lot of that because he put me together with a politician, and I'm going to ask him how to make things work, and they often give very, very good advice. So the point is that everything is not hunky-dory here, and we still have a lot to do closing the gap, and we continue to do that. But let's go to the broader region. Now, we are the gatekeepers to the Pacific in a way, because that seems to be where we have focused a lot of our energy on. But we are also part of the Asian region, and half the world lives in the Asia-Pacific region. So, and they're getting older. There's a lot of disparity in terms of the eye disease, the economic development, and availability of eye services there. But also remember that 50% of the world's glaucoma population lives in the Asian region. So we've got a very peculiar problem, as we have that of myopia and macular degeneration. So we've just got to work our way through this while we help other nations in terms of what the right focus should be. My own association with the Pacific started when I came to Papua New Guinea in 1994. And there I was employed by the government, but the government didn't have any money. So they employed me, and then I was lucky to meet Mr. Sultan, who was a businessman and wanted to start and do something in the name of his late sister. So we started the Lela Foundation, which was the name of his sister. And along with the funds from the Lela Foundation and of course, the mandate from the government, I was able to start teaching, training, as well as some of the most complex service delivery programs in Papua New Guinea. So there I've been on all 3 rivers multiple times, where we've gone and taken the service to the villages. And Papua New Guinea has the Fly, the Sepik, the Ramu. They are big rivers. The Sepik is 3,000 kilometers. So there's plenty of population on either side. And so that was interesting, because it allowed me to see bits of PNG that most people haven't seen. This was a caravan that we took from Madang, and that banner there was painted by my wife, Anu. But, you can see that inside the caravan is where we used to live, where we used to operate. And sometimes we'd be doing 5,000-6,000 cases a year. This is how patients would come in their canoe. And in the end, Mohammed got knighted, but unfortunately we lost him to COVID. He married Dr. Amina, who's also an ophthalmologist, and she carries on the legacy in Papua New Guinea. So Lela Foundation not only did eyes, but they also gave scholarships. We did artificial limbs, and anything that would improve the quality of life of a Papua New Guinean. These are some recent photographs she sent me from the Southern Highlands. And of course, Lela Foundation, which was founded in 1994, is well and running. So I'm very proud that something like this still carries on. After being held up 3 times with a gun in Papua New Guinea, I moved to Darwin, where I looked after the Northern Territory's top end, which is really Catherine Go and Darwin districts. But while all that was going on, we had a problem unfolding in Timor Leste,
da ONU entra
where
em Timor. É a interferência. Encontrar
after the referendum, that's the first time I actually saw an East Timorese, because 5,000-6,000 of them came down to Darwin, and then we realized what had gone on in East Timor. But basically, the country was destroyed. And WHO, or the World Health Organization, contacted me and said, "Look, can you come and see what you can do here?" So I went there on Easter Monday in the year 2000, and then saw what a mess everything was, and then came back in July with the first team. This is the first team that went in. He was my registrar, the two optometrists, and you see Margaret, who's in WA now, came with me then, and then Professor Bilson from Sydney. So, and that's the old hospital. So we would go there 4 times a year, see patients from sometimes 6 till 10 at night and operate. And basically when we ran out of supplies, we just went and then came back when we had some more. These are some of the patients we treated. The results of violence, this patient with a burn with a skin graft there, this gentleman who was holding his glasses up with a pair of shoelaces. But, it didn't matter what it was. If we could do it, we would do it. This is the operating theater that we had in Dili, in the hospital. We had 3 beds in one theater. And you can see we utilized television screens so that the nurse could see. We had more surgeons than nurses. So she could see what was going on and then help out. So this first 4 years ended in the year 2004 when we ran out of money. I ran out of friends. And then I wrote, told the president at that time, Zanana Gusmao, I said, "Look, thank you. I think we've done our bit." But he said, "You can't go. You have to set up the program in Timor-Leste for the future." So that was Sergio Di Mello, who was the head of United Nations at that time. And he said, "No, you can't go. You have to do something." So I said, "Fine. Let's try and earn some money." So when Zanana Gusmao came in 2005 on a state visit, in between his different appointments and official engagements, I traveled with him in the Prime Minister's aircraft. And in that week, we had a lot of eye-related stuff going on, and we raised $750,000, which allowed me to start the program again. That was my first taste of what these diplomats do, because we had George Teme, who was then the ambassador, and I forget her name. She was the Australian ambassador to Timor-Leste, and Abel Guterres, who then became ambassador, and of course, Zanana Gusmao, who was the president. So I learned a lot, but it allowed us to start the East Timor Eye Program in 2005 with the end point of handing it over to the government. So it wasn't going to be an open-ended plan, and that's what we did. But with that money, we started going out to the districts. So we were, instead of just Dili, we were able to go to all the other districts, and we were also able to concentrate on Okusi, which is where the Catholics first landed 450 years ago. And those days we went by United Nations aircraft with a ton of supplies and operated there. That's the Okusi airport. Now, of course, it's much, much bigger. It even has an aero bridge that Hobart doesn't have. So I don't have photographs of it. But the one problem that we had faced then was that everything presented late. What you're seeing here is a melanoma of the eye. But again, we did what we did. It didn't matter whether it was cataract or not. We handled cancers, we handled reconstructions, anything that we could do. But the one thing that was missing was the fact that the program was episodic. When the team came, there was a program. When the team was away, there was no program. And we changed that by employing 3 international ophthalmologists. First, Dr. Naidu from India, then Dr. Andreas from Switzerland, and Dr. Manoj from Nepal. And so we employed them over a 16-year period, and that allowed us to convert the program into a 365 days a year program. And that allowed us to set the foundation for the future. As you see here, when they go out to the districts to operate, all the people who are doing, whether they're doing injections or starting the generators, they're all Timorese. So the team became Timorese, and the reliance on external, manpower and external teams became less and less. We even got a mobile operating theater from the Indian government, which allowed us to then go to even other places where there were no health centers. And the rule that I introduced was 1 month after surgery, you have to go back and see your patients. And there used to be resistance sometimes because you look at the state of roads in the wet season. But I said, no, if the car in front of you gets through, you go through. And so that's something that even exists today in terms of audit. But you can't have a program without headquarters. So in 2011, we helped the Australian government and Fred Hollows Foundation New Zealand, who put up the building, and we equipped it, and it became fully operational in 2012. Now, just to show you, this is the kind of surgery that's carried out there. It is a manual small incision cataract surgery, which is a very elegant surgery, does not require much in terms of equipment. It produces results that are quite the same. You can see this white cataract inside the eye, and a little hole is made to get a little bit of the lens out and put a new lens inside. So these people who come with these kind of cataracts are completely, totally, and utterly blind. And in fact, in Australia, in the training program, we don't teach our people to do this. And so many of them can't work in the surrounding nations. So I've set up a training course for them where they learn how to do this. They can even go to India and Nepal to learn this so that they can come and join me in these visits. So you can see here the last bits are taken out, and the new lens, this is the lens that's put inside the eye after cataract surgery, is put in. So 7 minutes, costs $15 US, and you can do as many as the day allows you to do. So it's got good results, and this is the standard of cataract surgery in most part world. Here are some pictures from inside the center. And not to say that's the only surgery we do, but we also, for selected patients, we also utilize the same surgery that we would do in Australia and New Zealand. So it's the full spectrum. The other big problem that came up was training the ophthalmologist. There was no university. Some people were trained in Cuba. Some people were trained in Indonesia. So in 2005, we embarked on training of the first ophthalmologist, Dr. Marcelino. And I set up a program with him for him in Sydney. And the first part was remote training. Then he came to Hobart and spent some time shadowing me and learning the medical aspects of ophthalmology. And then I sent him to Nepal for his surgical training. So there are some views of him in training when we went to Delhi. And that's Paul McCartney, my colleague, who has also been part of the program and has been helping in all this. So he's a true ophthalmologist, international ophthalmologist with international input for his training. But one ophthalmologist for 1.2 million people, that doesn't work. So we got on to the next part of the program, which is to train more, but in countries. So even though the Cuban medical trainers were there, we started training program in ophthalmology under the University of Timor Leste. And all the Australian and New Zealand ophthalmologists who used to go there became teachers. And really, we started training cataract surgeons in a 1.5 year program. And they were, here you see some of the registrars in action. That's Suzani, she's now doing further training in Fiji. Pedro is going next month to do further training in China. And so on. So, they've been practicing and they've been going. But we've also introduced other things like corneal transplant services in 2009, and also worked on getting people short-term connections or short-term fellowships to learn specific skills. So you can go for 6 weeks, learn something, and come back. We also have a retinal unit there where we do retinal detachment surgery, and also managing the complications of diabetes. But if you look at the operating list there, it's obscene. It's a lot of work when we go there, but it's a lot of fun. And we added telemedicine way before we even introduced it in Australia, so that we had a further footprint for the program. But it's not only about doctors. We also trained the nurses. We trained optometrists. And you see Michael Knipe, some of you may, he died, but he was instrumental in helping us in getting this training going. So they have a full-fledged lab that makes glasses, and the glasses are sold anywhere from $1 to $10 for ready-made spectacles to $25 for custom-made spectacles. We have services for people who are irreversibly blind, like we have them here. That's the East Timor Blind Union. We also have a laboratory for making artificial eyes. And next month, Philippe is coming to Darwin for further training. So we also have trained biomedical technicians who keep all the machines humming, and have, that's Rob Walsh from Hobart, and Norbert from, that's Norbert, and that's Rob Walsh from Walsh Optics in Hobart. So, at the 10th year of our existence, a lot of younger people wanted to come, but as I told you, they were not in a situation where they could help. So we decided to put up a scholarship from my practice for $25,000 a year, where they could go to India, Nepal, learn, and come back and work in Delhi. We also addressed the problem of diabetes by utilizing this camera from India, which has got artificial intelligence built into it, and we could take it across to the districts in a backpack on a motorcycle. One of the things that is unique in Timor Leste is that we put together a 30-year plan for them in an effort to future-proof the plan from changes of government. And so they have a plan till the year 2050, and which makes it much easier for anybody to come and, work there and help. We have handed over the program to the Timorese in December 2023, and are now looking at, different ways where we can continue to support them. Some of the defining moments in this journey has been the first graduation ceremony. That is Dr. Bernadette, Dr. Julia, who's now head of department, and Valerio, who's the retinal surgeon. So they are now running the show. And there are others, one coming from South Korea and two more from Fiji, and then there are others who are going. So it just carries on. So as you can see, it's a small program that started from, Hobart in a sense, but it's actually spread from around the world. And this has been possible because of the relationships that we built up over the years. So rather than dwell on how many cases we've done, I think you need to really put in front of you what the impact has been. So this data is now 5 years old, the pre-COVID. And so 15 years ago, the prevalence of blindness was 7.7%. And then it came down to 2.8% 10 years later. And this was done by an independent audit which is carried out by the International Agency for Prevention of Blindness. So that's the impact of something like this. And it's thanks to this group, who are the doctors, nurses, and other staff who look after the eye health of Timor-Leste. So it's a complete eye care workforce, and we still have to carry on. But based on this, we got approached by Western Samoa and other countries in the South Pacific, where the problem of blindness still remains an issue. So whether you look at the whole Oceania group, or you look just at the South Pacific, the stats for eye care, the stats for blindness, the stats for visual impairment are serious. In fact, 6 of the 10 countries with the highest rates of diabetes are in the Pacific. And you know that diabetes is a significant cause for blindness if left untreated. So we're not only looking after Melanesia and Polynesia, but also looking after Micronesia. So we, as a college, what are we doing? We are doing what we've always been doing in terms of training. But this year we decided we'll focus on Samoa and Tonga, and then Kiribati, as well as deal with the Pacific as a region rather than 14 specific countries. So what else is in the pipeline is that all the international links that I have, whether it's the Americans, the Indians, and so on, they're all channeled through Australia and New Zealand, through the college, when they want to help in the Pacific. So we're also looking at advocacy at the government level. And so that when we go in, and we've already gone in, there will be, aid will have its full components, not just medical, but also political and bureaucratic. We are addressing the issue of climate change, and we know that climate change is very dear to the hearts of the people in the Pacific for obvious reasons, but even in Australia, it's an observable threat. I don't have to tell you that it's an issue, but and healthcare is a serious emitter of greenhouse gases, and so is ophthalmology. We are one of the highest surgical volume, in the country. So we've been actually carbon footprinting our cataracts, and what you see here is the carbon footprint of cataract surgery in New Zealand, which uses hydro a bit like Tasmania. And this is the carbon footprint of the procedure that I showed you. And that is what we are using in the Pacific. Again, we are looking at the various options that we have, including following the example of India, which eliminates emissions by not packaging everything 3 times and also reusing items. We're also looking at the carbon footprint of injections, and above all, creating partnerships. One of our biggest allies is the ophthalmic workforce in India. They have 28,000 ophthalmologists. And so we signed an MOU with them, and also wrote a letter to the Indian Prime Minister talking about diabetes in Australia, New Zealand, and of course in the Pacific, and that we are working together. And I brought this to the attention of my ambassador in Canberra, and Her Excellency agreed to hold an afternoon tea in the embassy, and where she invited all the Pacific heads of missions. You see Samson Fare from Vanuatu and the gentleman from Indonesia, but where we highlighted what was achieved in Timor Leste so that we could then ask them to advocate for eye care in the Pacific at their own government level, and it's worked. Following that, we had a chance when we went to India to have a session with the All India Ophthalmic Society and the Australian Embassy. That gentleman is from the Australian Embassy. He's the president of the All India Ophthalmic Society, and so on, where we outlined what we were doing in the Pacific. And this then translated to a visit to Samoa in May. And you can see the same sort of banner, All India Ophthalmic Society and RANSCO, where we then met the Director General of Health Services and outlined what we were going to do, and got, and got the ball rolling. So India has pledged to do anything and everything that is necessary to eliminate avoidable blindness in Samoa. And then we'll move on to other Pacific countries. You can see the operating theater in Samoa. And that's Dr. Lucilla, who's the only ophthalmologist in Samoa. So it's one ophthalmologist for 220,000 population. We moved on to Tonga 2 days later. And there we also spoke to the Australian ambassador or high commissioner and informed him what we were doing with Tonga. Tonga has got 110,000, but it's got 2 ophthalmologists. But look, if you look at the, the ratio, it's still appalling. And we've set up a WhatsApp telemedicine network all over the Pacific, and are able to share. And it's actually very busy, so that nothing is left for too long. Within 24 hours, you get a response guaranteed. And he was the second ophthalmologist from Timor Leste, and he's now working in Vanuatu as the only ophthalmologist. So you can see that movement has started and specifically supporting itself. We also have buy-in from the National Institute of Health in America, in Maryland, and they are looking to join us to help the Pacific. Their budget for this institution alone is $50 billion, B for $1 billion, and they want to share it with the region. So, all these connections, all these partnerships, I think will help us as we move along. So if we move to the side and leave the iPad out of it, over the years, we've been able to do lots more based on the success of the Eye Program. We've had scholarships from the University of Tasmania. We've had sister school projects, MacKillop College, Farn School, and others. And of course, now the big guest worker program, which we've got more than 1,000 guest workers in Tasmania. And of course, the programs from St. John's. One of the programs from St. John's was supplying about 720 first aid kits in partnership with the Order of Malta to all rural schools in the country, along with instructions on how to use them. This is the school in Daisoli where we have given desks as well as built 2 classrooms. That's when we installed the Timor Leste plaque in the International Wall of Friendship. We had a program called the Toys for Timor program, where we've sent toys, but then later on 2 containers of toys to the First Lady, who's distributed them. But I think the most visible part is the Timorese contingent on Anzac Day, where this time over 180 people came in and marched on Anzac Day. That's the High Commissioner giving an address, and we also had the Secretary of State for Labour marching with us and giving an interview to SBS. It's become a regular feature for the past 9 years, and I think is well regarded in the community. The ambassador also made a state visit where we looked at various projects to work between the two states. And following that, we just returned from a Team Tasmania visit to Timor Leste. It had 3 components. So, and I'll come to that. But that's the Australian ambassador, Caitlin Wilson, whom we appraised of what's going on. That's Carl Graham from St. John's Ambulance, Tasmania, where we're looking at a number of first aid and first responder projects. And then we've also got Greg Melick from RSL. So we've been able to get them to come along and see what can be done. Give us a very, very good welcome.
Excuse me, Nitin.
The VIP.
I'm conscious of the time.
Yep.
You got much longer?
I'm done. No.
Sorry, I didn't want to cut you off. Just
No.
yeah,
I'm done.
Just time here.
Also concentrating
so that's great.
on Otauro, where we're thinking of first aid and something with aquaculture. So we've discussed all that, and hopefully we'll get things moving once I recover from this COVID. And so essentially, this has been a learning journey. And now that Timor-Leste is part of ASEAN, I think we'd be able to indulge in nation building even more. I leave Dick to handle Project Lulu, which is his baby. But we've got a catamaran going to the Pacific Islands called the Pacific Hawk, carrying supplies and running clinics there. But all this came to a head in 2007 when I was asked to be the honorary consul. And since then, it's been learning, and I learn even more from my colleagues in the consular corps. But basically, I think this is a time for action. We need to recognize there's a growing burden of vision loss in the region. And I hope that during the Samoa Commonwealth Heads of Government meeting, we're able to get a statement regarding the importance of eye health in the agenda. So as we work towards global health diplomacy, I think we are on a pretty good wicket. And now that we have buy-in from governments, hopefully we should be able to get there. I'd like to also acknowledge 3 of our colleagues who died as part of, during this journey, and also thank the Institute as well as the other people who have helped me understand what it means to practice some form of diplomacy. Thank you.
Nitin, you're an amazing man. I think everybody in the room is actually full of admiration for the work that you and your colleague are doing, not only in Timor-Leste, but around the world. So if you'd like to just hang on in the background there for a little while, I'll introduce Dick Warner to speak. Now, in introducing Dick, it says here he's a board member of the Hobart Community Shed Limited, chairman of the Tasmanian Agricultural Education and Training Partnership, chair of the Tasmanian Committee of the Crawford Fund, and the independent chair of Agri-Skills Reference Panel, Tasmania. So as soon as Bruno organises the electronics, we're ready to go. Would you please welcome Richard Warner?
Good evening, everyone. Can you hear me? And thank you all for coming out on a cold night, and thank you very much for asking me to talk about the Crawford Fund, which is where I'll concentrate, and then a little bit about the work we've done in Timor. Now, you've probably never heard of the Crawford Fund. The Crawford Fund is a 35-year-old national not-for-profit entity which contributes to food, nutrition, security by encouraging more Australian involvement and supporting high-quality science-based projects in developing countries. Each state and territory has a committee, and our headquarters are in Canberra. Crawford works very closely with the Australian Centre for International Agricultural Research, commonly called ACR. ACR is a statutory body within Department of Foreign Affairs and Trade. The Crawford Fund was named in honour of Sir John Crawford. Sir John was an agricultural economist and a key architect of Australia's post-war growth. Sir John was also a passionate supporter of international agricultural research. Crawford's mission, briefly, are to promote the benefits of its work to developing countries as well as in Australia. Now, that's important for us. We know the work we're doing in developing countries and that the evidence is clear. But what we're trying to do also is determine what benefits accrue to Australia from the work we're doing overseas. We raise awareness of food and nutritional issues. We support Australians in training developing country scientists and farmers. We encourage young Australians in their careers, studies and volunteering for food and nutrition security. The key activities: public awareness, capacity building, that is training people in other countries, mentoring. I'll go back to capacity building. I just want to mention masterclasses, which we now run. I think there have been 65 of them held throughout South Pacific and Asia. And they have been an enormous success, and we look to expand that quite dramatically over the next year or two. Mentoring, sustained involvement by Australian experts, and the next gen, which is researchers in agriculture for international development, are the group of young people who Crawford support, and we encourage them to get involved in international aid. And to me, it's one of the best things that we actually do, is encouraging young people to get involved. Some of the examples of our key activities: the conference. We have an annual conference every year. This year it's in early August, and we try and hold it in Parliament House, and this year it's where it is in the Great Hall in Parliament House. About 500 people come. We invite keynote speakers from all over the world, and they are, it's just one of the joys to see the young people mixing with the experienced people, with the world's experts in this area of food, security and nutrition. Some of the speakers we've had: Dr. Kerry Fowler last year, keynote speaker, Special Envoy on Food Security. We've got here our Minister for Agriculture at the time, where we launched what we call By Doing Well, By Doing Good at Government House. That was launched in every state, and we did it at Government House last year. The capacity building, a few examples here. We've had 65, as I said, bringing together about 1,600 researchers through many countries. We've had research and leadership management in Penang in Malaysia. We've done gene bank operations and advanced learning in New Delhi, communicating research to stakeholders in Fiji. Some of the capacity building and training Tasmanian examples include training of management of sandalwood production in Tonga, water pump installation in Ballyboe. I want to come back to that and just talk about that, but I'd like you to have a look at that image of drums and a tap. I'll come back and describe a little bit more about that a bit later. Soil issues affecting forestry in Vietnam and writing research papers for publication in Indonesia. Mentoring. Hang on. Mentoring. I just want to mention here the extraordinary work done by Dr. Chris Harwood and Professor Rod Griffin with forestry in Vietnam. They've been going there a long time now, and they have built up a level of expertise in that country, which their forestry of acacia and eucalypt is now being harvested and used throughout the world. And that's all been driven by those fellows from here. Dr. Stephen Ives on improving the lives of small landowners in Vietnam. He's been going there a long time, and similarly, great results have come around from his work. The next gen of people, I've mentioned really about them. We try and bring them together to mix with the more experienced researchers, and we do that by way of the conference. The conference scholarships, each state calls for expressions of interest from students to become what we call a conference scholar. And we send them to Canberra for 3 days. The first day they are joined up with a mentor. They then mix with the other scholars from the other states, but they also mix with experienced researchers. It gives them a real taste for what international aid's all about. I won't read them, but you probably can read the comments there from people that have been and done it. And it's this year we've got an unprecedented 9 scholars we're sending up in a few weeks' time. Student awards. These are awards we also call for expressions of interest for students to do a travelling scholarship. That is, going to a country with someone, with a mentor. I'll point out Oliver Gales in that top right-hand side corner. Oliver went to Timor Leste with Chris Thompson on water and school farms. Oliver, now, I'm not sure what year that was, but in 2021 too. That fellow represented Australia at the COP28 conference in Dubai last year. Extraordinary. Lisa Cooper went to Fiji. She now works for the ABC, doing wonderful stuff. So we've got 3 applicants which we've confirmed this year. Volunteering. I'll just mention this Gillian Lyle swap bushwalk guiding in Tasmania for lab and field work in southern Laos as a plant pathology volunteer. You do find, as I have found, going to Timor Leste, my words, fall in love a bit with the country and the hardship and the things that we can make better. I now want to just talk about, in a little more detail, if I may. If we look at the top left hand from your side, that's a school. That's an existing school. It's been replaced by this building here. It's done by Ballybough House Trust. I'll mention them in a moment, a bit more detail. They have built schools, but also Spend It Well is another charity which has built schools, and they actually built this one. I just wanted to show that, to show you what you can see there and what you can do. Okay. If you recall back to that photograph I had of the tap and the drums, in Ballybough, there are 4 springs that supply the water to that town. And each of those springs is a pump. And one of the pumps wasn't working. So say 25% of the town didn't have immediate water. And the water is reticulated throughout Ballybough to these communal points where you take your drum, fill it up, take it home, boil it. It's got to be boiled. It's not drinkable. So you'll find around the houses in Ballybough, all the trees have been cut down to light a fire to boil the billy. That's one of the pumps. And in fact, I went with Abel Gutierrez, the then ambassador, and Chris Thompson and I, and we found one of the pumps wasn't working. So we went through the process, and I won't bore you with that, but we did replace it. And by that stage, we were training the locals as well in how to manage these pumps. And after we got it all going, I received emails after email from the locals telling me how they'd never had water before, like they're having it now. So all that is extremely rewarding. Now I've put the top photograph showing a riverbed. It's just to show you that getting around Timor is not all that easy, particularly in the more remote regions. That's a riverbed because it's very much a dry season, wet season. And those group of cars are going towards building a school in a remote part of Timor. Here we have, after we'd repaired the pump, supplied the water, we then had to purify the water so that the locals could drink the water. So we found in Queensland a company that were making a filtration plant. One of them is here. It's called a sky hydrant, and there are many of them now all over Africa and Asia. And Crawford, my organisation, went into partnership with Engineers Without Borders, and they have an office in Dili, and also with the Ballybough House Trust. And between us, we have fitted up 6 schools with these sky hydrants, with these filtration plants, because it's the kids that take the water home. So we're fitting them up in the schools so that it's easy for the kids to fill their bottle and walk home with it. It's been a really rewarding. Now, one of the, Nitin mentioned briefly about a project that's ahead of us that we are very excited about. It came about from an IMAS professor taking his son to Timor for holiday. And they went out to the island of Toro, which Nitin mentioned, which is just off Dili, where the ladies of the island catch tropical lobster. They bring them in, they're shipped to Dili, which is a couple of hours by boat. There they sit on a table in the marketplace, no protection from the sun, 35 degrees heat, and by the end of the day, those crayfish are beginning to deteriorate. And so the fisher back on Otoro is getting very little money for those fish. So my professor from IMAS said, we know all about post-harvest handling of fish. We know all about cooling fish, keeping them in good condition. We know all about that in Tasmania. Why don't we do that up there? So we're in the process at the moment of developing a concrete plan that will involve a whole range of players, including, I hope, Crawford, to do a pilot with the lobster on a Toro, taking them to Dili, supplying them to the upmarket hotels in Dili, which at the moment they're getting $5 for a fish. We hope to get $50 to $100 for a fish. That money goes directly back to those fishers and improves the livelihood. It just doesn't improve nutrition and food security, it provides more wealth. And so we're really quite excited about that one. I've got very little more to say about Crawford, but we work so closely with ACR. I've mentioned them. We're hand in glove with them. We run on a very small amount of money. Each of the committees in each state are all teamed by volunteers. No one's paid anything. We've got our administrative staff that are, but everyone else provides their time for nothing. And we actually pick our projects so that we can value add what ACR are doing in many instances, so that we can make our little dollars go quite a long way. And over the 35 years we've been operating, I'd have to say that we've been extremely successful. And research, agricultural research in developing countries shows a reward of 10 to 1. Every dollar we put in, we can get 10 back. It's worth 10 the other end. So for me, it's been a joy to work with Crawford, a joy to work with the young people, and a joy to work with those older people. So thank you all for listening to me. And before I go, I'd have to say that Nitin is an absolute star. What he's done in Timor is extraordinary. Thank you.
Thank you very, very much, Richard. I just don't think anybody realised that, what expertise we've got in Tasmania and what we're actually working on overseas. This has been a real eye-opener for me and I guess for a lot of you as well. So thank you for coming around and sharing that with us, Richard. Now, I'm mindful of the time. Nitin, you're back with us. Have we got 10 minutes for questions? You up to it, Nitin, or is your conjunctivitis playing up?
No, I'm fine. Look, I'm sitting at home. You're the guys who
haven't got a meal ready for you yet?
Well,
no worries. Are there any questions? Okay, we've got somebody right in the back. Bruno, would you like to take the microphone out? Because the only way we're going to get Nitin to hear the questions is through the microphone system. Anybody else while we're waiting for this one? I'll take the microphone up this end.
It's a question for our consul, I think. You're doing a lot of work around, or have been doing for some time, a lot of work around a lot of countries in our region. One of the other major players in that area is becoming China. Did you have any interaction with China at all as a source of funds, as a source of collaboration, as an irritant, as a who knows what?
Well, we have, I think, we've been dealing with Chinese medical teams in Timor right from the beginning. And we've had, a team of 20 would come to Timor Leste, and now I'm talking of, going back to 2006, 2007. And we've had some very good teams, and we've had some not so good teams. And, I've discussed this with the Timorese, and they themselves have at times gone to the Chinese doctor. In fact, even a Cuban doctor, where they've gone and said that we would rather you don't operate on Timorese patients. So the way to deal with those kind of quality issues has been through the host country. And we've had the same problem in Papua New Guinea also when I was there. In fact, in Papua New Guinea, it was worse. But there's a Timorese ophthalmologist who applied for going to China for doing further training, and he is going to a good institution in China, and he has asked for funding for airfares and relocation and so on. And I said, look, that's a good institution, and I hope that you will get a good education. So I have agreed to fund his going there from personal funds. But at the same time, it doesn't end there, because at the same time, the Timorese ambassador to Beijing is well known to me. So I've told him to make sure that young man is looked after. On the geopolitical front, I suppose you know everything. We don't deal with that side of things, but in the medical field, it's been good and bad both.
I just want to congratulate you. I have a medical background, and I can just underline the brilliance of what you're talking about. I was at Vellore in about 1960s, where they had a clinic for 7,000 leprosy patients, things like this. And I just want to thank you for expanding our horizons and congratulate you. I want to ask you, what would you dream of now? What would be the things you just wish that you could do, both of you, that you need some help with?
Well, I think if we can, it's so sad that after so many years of saying we're helping the Pacific, both at an individual level and also at a government level, we haven't been able to achieve self-sufficiency for countries with a population of 100,000, 200,000, 600,000 in something as simple to do as eye care. And my hope is that we would be, amongst other things, be able to help our neighbors in a little more serious way, and would really like to put, lack of blindness or lack of visual mobility up on the agenda, because you can't imagine what blindness is like. It's terrible. And so I just hope that we can bring this up to above the horizon. Right now, it's much below the horizon, above the horizon, and that can only be achieved by advocacy. And I hope that the politicians get it, the departments get it, and then together with the donors, we're able to solve at least one problem, which is one of many.
Richard, do you want to add to that? No comments. I might just wind up the questions then. And once again, Nitin, thank you very much for putting up with the COVID at home and making yourself available tonight to speak with us. And Richard, thank you also for coming along. I think both speakers have been marvellous. I think we're very, very fortunate to have people of their calibre here in Tasmania.